Well, this is the HemOnc Pulse again, but we are dealing now with episode 2 of the. We're gonna end up having a series, guys, about this CAR T and secondary malignancies. I mean, before you know it, we'll be on the TV with like a syndicated show and like a short documentary in Netflix. Let's not don't get me carried away right away. But I have the honor of having Dr. Saurabh Dahiya and Dr. Jay Spiegel with me on the HemOnc Pulse. They both appeared on the first episode of what we are trying to make sure cover and uncover of CAR T and secondary malignancies. So before I make a quick intro, I urge you guys who are listening and viewing this to really go back and and listen and view the first episode that we taped just a few weeks ago. And after we taped it, we connected the three of us and we realized there's some new things that have actually developed. And as we always keep our fingers on the pulse and on the HemOnc Pulse, we jumped on the call to tape this episode. We even, Saurabh, we had to wake up Jay a little bit because he's on the East Coast and we're taping this for context, everyone. This is February 7, 2024, and it is 9 p.m. Eastern Standard Time. This is how committed these two amazing investigators are to the science. So Jay, will start by you in terms of just a quick intro, and then we move on to the West Coast with Saurabh.
Sure. So I'm Jay Spiegel. I'm a transplanter and cell therapist at the University of Miami. It is in fact 9 p.m. My kids are still awake, so hopefully they will not interrupt. But I primarily focus on CAR in aggressive lymphomas, but also in multiple myeloma and B-cell lymphoblastic leukemia.
And Jay, I could tell you as a host, I would want your kids to interrupt because this will get us more clicks and more views. So you'll have, when you're in my shoes, you want the kids to interrupt.
Well, I can hear them, so I hope you guys can't.
Not yet. Saurabh, what about you?
Yeah, my kids are not going to interrupt. They're home. I'm just wrapping up my clinic, and it's 6 o'clock here on the West Coast. So nice to be on this call again and this podcast again. Shadi, thank you for having us. As a way of introduction, my name is Saurabh Dahiya. I'm a hematologist, medical oncologist, and cell therapy physician here at Stanford University. I'm an associate professor of medicine, and I serve as the clinical director of cancer cell therapy program. My clinical focus is primarily lymphoma, but I'm involved in all things cell therapy here at Stanford. Nice to be on this call.
You guys both were with me literally just a few weeks ago, and we sat down and we talked on the HemOnc Pulse about some emerging data on CAR T cellular therapy and secondary malignancies. And we are on this call because there have been some recent developments that we must cover. But before we delve into these, Saurabh, do you want to put things in context in terms of like summarize a little bit into what we talked about? And then I'm going to ask Jay to say like what happened that we are having this podcast again.
Yeah, I can summarize what we talked earlier about. And in November of 2023, right around Thanksgiving, FDA issued a warning and opened an investigation on this new observation of secondary malignancies after CAR T-cell therapy. The main concern was development of T-cell lymphoma after receipt of CAR T-cell therapy. They reported at that time 19 cases of T-cell lymphoma after CAR T-cell therapy. They did say at that time some of those cases are CAR positive, which means that the transgene for the CAR was detected in the T-cell lymphoma itself, Since then, we have learned in the context of T-cell lymphoma that there have been a total of 22 cases. A couple of weeks ago, there was commentary in New England Journal of Medicine by the director of Center for Biologics, Dr. Peter Marks, where they updated that number from 19 to 22 cases. And they talk about 3 cases of those T-cell lymphoma being CAR-positive lymphoma. So
there's no question, if they're CAR-positive lymphoma, they are from CAR. I mean, there's like, it's 100% from the CAR T therapy. these three cases?
So we don't know the details on those three cases yet. We know about one of the cases, which was, as we previously talked about, was an ASH online only presentation. We don't know much details, but it's yes, CAR gene was seen in those patients, but it is unclear whether CAR was directly implicated there or not, because there's in that analysis they showed that CAR inserted at a very distant locus
Oh,
from
yes.
the mutation that was seen in the T cells T cell lymphoma itself. Uh, but I mean, yes, we can't deny the fact that there are three cases which are CAR positive, and has always been a concern in the field that if CAR insertion itself would lead to what we call as insertional mutagenesis in cancer. So we saw three of those cases. We don't know the details fully just yet.
And Jay, we talked in the last podcast that this is important for people to know. And I recall you guys telling me that there's really nothing in there that will change your clinical practice. You would probably talk a little bit about it, but you haven't seen anything aside from counseling patients and keeping your fingers on the pulse, knowing really what's going on. We taped this podcast sometime in January. We are now February. What has happened since then, Jay, that prompted us to get back on this podcast to update viewers and listeners? What have you learned?
Yeah, so I would agree with Saurabh. I mean, that particular paper in the New England from the FDA came out the week that we taped. So I think that gave very important context. Previously, the FDA press release had said that there were 19 cases that had been reported through the FAERS mechanism. So anybody can report through that mechanism. It was not really clear that there had actually been genomic testing in any of the cases. So I think it was important that the FDA in that New England article said that they had evaluated 14 cases. So they haven't been able to get information on all of them, but like Saurabh mentioned, they had been able to find CAR transgene in 3, and certainly that's suspicious for whether the CAR is going to be implicated in causing that lymphoma. But then as a result of that, they also, that same week, came out with a requirement to add a black box warning to all of the approved commercial CAR Ts for the risk of T cell malignancies after commercial CAR T therapy. So I think that's a very important change to the label. Whether or not that's going to change the way that we approach the treatment of these patients, I think is still similar to what Saurabh and I discussed initially, but that is definitely an important change that we have to note that it's now been added to the label.
Saurabh, the black box warning has nothing to do with the type of disease that we are treating. Is it? It doesn't matter. It's if a CAR T is commercially available, there's a black box warning.
Yeah, they saw there's 6 FDA-approved therapies for in hematologic malignancies, none in solid just yet, and 2 for multiple myeloma and 4 for lymphoma. And across the board, across all these 6 histologies, there have been cases of T-cell lymphoma. So yes, I mean, at this particular time, all of those US labels have that warning on them.
So what's Jay? What's your read? Like, what's the black box? I'm gonna try to see what's the black box warning in terms of language. Your recollection. What did they actually say? Just descriptive or warning? What is it?
Yeah, it's more descriptive, and I think it's twofold. You know, the FDA said that they want to bring awareness to this. Part of the initial approval of these therapies was that there has to be 15-year follow-up for these patients, and I think part of this was to reinforce that we need longer-term follow-up for these patients. We need to continue to follow, and I think that it was also to try and encourage reporting. So I think we had talked about that, you know, not all T-cell malignancies are created equal. So I think the positivity of the CAR transgene, I think that's certainly a problem that we can associate with the CAR, but we mentioned that patients with B-cell malignancies, for example, can develop T-cell malignancies even without CAR. and whether or not that's going to be increased in the context of somebody that has previously received the CAR still remains to be seen. However, the FDA did voice some concerns about whether there had been some underreporting. And so part of their perspective piece was to try and encourage people to come forward, people to look, just to see that we're getting an accurate sense of really the problem, as it exists. Is it really just 3 cases, like we mentioned, that have CAR positivity, and therefore, put it in the context of having 34,000 infused, that remains a relatively low risk when you're talking about patients with relapsed refractory aggressive malignancy? Or is there something that is perhaps a little bit of a larger problem that we need to recognize? And I think that's part of why the FDA is coming out so strongly thinking about this.
Saurabh, when I when I look at the there are 6 letters, like you guys mentioned, on the FDA about safety warnings, and all of these letters came out on January 19. So like a week after we taped the first podcast. And an example of a letter, for example, an example of a letter was sent to the manufacturer of Yescarta. They talked about box warning highlight section in the PI about the T-cell malignancies, box warning, full prescribing information, all of these things. And then they say, patient counseling is very important. And then in accordance with the section 50504, within 30 calendar days of the date of this letter, which was January 19, you must submit a supplement proposing changes to the approved labeling in accordance with the above direction, or notify the FDA that you do not believe a labeling changes is warranted, and all of these things. Do we have any reaction? Are we aware of any reaction from manufacturers when this actually, it hasn't been 30 days yet, but do we know any reaction at all?
I'm not aware of the manufacturer perspective on this, Shadi, but so secondary cancers have always been on the label for all the 6 FDA-approved CARs, but there have been label changes. There will be label changes to reflect this T-cell development soon, but I don't have direct knowledge into what the specific manufacturers are thinking. One thing I think to highlight also would be, I think we are talking a lot about T-cell lymphoma, which is clearly a big discussion topic. The second also this issue of second primary malignancy or other type of neoplasms like myeloid neoplasms, secondary myeloid neoplasms, is also an emerging issue. Particularly with some of the myeloma CARs like cilta-cel or Carvykti. That particular product had a label change, which does talk about development of hematologic malignancies, including T-cell lymphoma and myeloid malignancies. So if I have to zoom out a little bit for just one quick minute, when we think about second primary malignancies after CAR T-cell therapy, there are 3 broad buckets that we need to think about those malignancies. Number 1 is these T-cell lymphoma. And in T-cell lymphoma, it could be CAR positive, CAR negative lymphoma, T-cell lymphoma. CAR negative, very rare event. CAR positive, very rare event. CAR negative is a very rare event too, but less of a concern. Overall, as I said, 22 patients have been reported out of 35,000 CAR T infusions in the US. Second big bucket of second primary malignancy is myeloid neoplasms, which are therapy-related myeloid neoplasms, and the incidence of those have varied based on different data sets that have been used. CAB-MTR data have been looked at. Us at US CAR T Lymphoma Consortium, we have looked at that too, and it ranges anywhere from 5 to 7% after a variety of CAR T cell therapy. And the third bucket is solid tumors, and etiology, pathobiology of generation of all these 3 big second primary malignancies is very different. So on the label right now, what we think is going to happen is this label change to reflect T-cell malignancy change, and then also second primary malignancy, which is subsequent malignant myeloid neoplasm, is also going to go on the label. for some of the product, like it has already happened for Carvykti.
This is great. I love those three buckets. I also I learned from you that we've treated 35,000 CAR T infusions. I did not know the actual number. This is very helpful for listeners to know the importance of actually following what happens in the real world outside of clinical trials. So this is very important, and thanks for clarifying this. Jay, my issue is that there's a lot of interest. I don't want to say hype, but there's a lot of interest in moving CAR T frontline. There are times when, when we first treated patients with CAR T, they really had no other choice. And frankly, you are going to take your risk because the other choice was hospice. But that's no longer the case. So there's interest in, in relapse disease versus transplant in DLBCL. There's interest in, even some folks are saying, could we actually move it in consolidation in certain scenarios and in clinical trials per se? How do you envision these attempts, even in a clinical trial setting, to be impacted by these findings or by these warnings?
Yeah, so I think there are a couple of things there. One, as far as the second line studies, to a large extent, there have already been several large studies completed in the second line. In large cell lymphoma, there have been three large studies comparing CAR T to standard of care chemoimmunotherapy plus auto transplant for responding patients. And two of those, one for axi-cel and one for liso-cel, were positive, leading to approval in the second line. And I would say in lymphoma, what we've seen in the past year is a migration of many patients being treated in the second line rather than the third line. That's certainly what I've seen in my practice. Those types of studies, I think, are ideal for looking for the incidence of these malignancies because you had patients treated with standard of care approaches as a comparator arm. So you can look for secondary malignancy incidence as well. I decided I wanted to write this down so I could give you the exact numbers. But in ZUMA-7, which is the axi-cel study, they reported 8 out of 170 patients developing secondary malignancies in the CAR T arm after a median 4 years of follow-up, 2 of which were MDS and AML. There were 3 cancers in the standard of care arm. And at ZUMA-7, I did not find anything reported from the liso-cel study as yet. It's a little bit of a smaller trial.
So that's 4%. 8 of 107, that's 4%.
Mm-hmm. And so that's at 4 years of follow-up. So just to put that in a frame of reference from the data that we looked at for standard of care axi-cel patients as part of the consortium that Saurabh was mentioning, we had 9% secondary primary malignancies, 5% of the total patients treated developed a secondary myeloid neoplasm. So a little bit higher, though obviously not really easily comparable. I think there's certainly some suggestion that perhaps if we treated patients earlier, if they weren't exposed to things like platinums in the second line for large cell lymphoma, for example, that maybe the development of secondary malignancies, particularly PMNs, might go down. So I think that following up that real world data in the second line now, but also following these trials up further will be really important. And just as a frame of reference in the multiple myeloma space, CARTITUDE-4, which is cilta-cel for patients who'd received 1 to 3 prior lines of therapy randomized against investigator choice, they're also reporting a lower incidence of MDS AML. So far, they had 2 patients with MDS AML in the CAR T arm. 4.3% of the total CAR T arm has developed a secondary malignancy. Follow-up's a little bit less. But there were actually more secondary cancers in the standard of care arm. So I think in the second line, I don't really foresee the same concern because I think we've already completed the trials that will allow us to get a sense of what the incidence is. And in particularly in lymphoma, we already have many patients treated in a commercial setting, and we'll be able to get some numbers on that hopefully in the next year or so. And Saurabh and I are trying to put some of that together. Moving even earlier, I think in the context of clinical trial, because the rate of T-cell malignancy is so low, I don't really think that changes the calculus if it's a trial that has good justification. For example, ZUMA-23 is looking at high-risk patients in the front line and randomizing to ongoing chemotherapy versus axi-cel. And that trial is already open and ongoing. And I have not heard, I'm not an investigator on the study, but I've not heard if there are any amendments
In
required for that.
what subset? What lymphoma?
In diffuse large B-cell lymphoma with IPI 4 or 5, so very high-risk patients.
So it's basically chemotherapy versus chemotherapy followed by CAR T?
So you can get one cycle of chemo, and then you would enroll and be randomized. And so then you would collect for CAR T, get a second cycle, basically as bridging while you're making the CAR, and then get CAR, versus 6 cycles of R-CHOP or R-EPOCH.
Got it.
And
I mean,
that
it's
trial's already
interesting,
ongoing.
right? Because I think you're dealing with a curable disease, and you know, the rate is so small, but it makes you worry a little bit with the boxed warning, black box warning.
Oh, absolutely. And I think, you know, to my mind, the you know, MDS AML, I think is probably a more relevant problem as far as how I think about these. You could, like I mentioned previously, you could perhaps justify that treating patients earlier with less exposure to prior therapy might result in a lower rate of secondary myeloid malignancies. But then, you know, the unanswered question is whether the immunosuppression post-CAR T may render patients susceptible to these types of cancers, which obviously moving forward into an earlier line, you wouldn't really negate that. So I think that is part of the question. I think it's going to be interesting to see how that impacts these trials, but I haven't heard of any changes so far.
And I look forward to learning about your work, both. Hopefully you can share with us when it's available on this podcast, when it's mature. Saurabh, did you expect to see a black box warning? I'm so intrigued actually now to go back and look at what makes it to a black box warning versus not. I haven't had a chance to look at this, but was this something that surprised you, I guess, when you saw this, or it was something that you thought it's justified and reasonable?
Yeah, I would acknowledge that I also should dig deep into what is the threshold to get on a black box warning. I mean, we're all very familiar with our when we give chemotherapies, there's a general risk of like more than 10% of the patient would get a certain toxicity, 1 to 10 would get a certain toxicity. And we don't directly attribute it always to the drug itself, but it's a combination of drug and the disease. So I think I'm not surprised that it ended up on the label, but I think that it doesn't prove causation. I think as a field, we still need to understand why these secondary malignancies are happening. These secondary myeloid neoplasms are happening. Is it the effect of prior genotoxic, DNA-damaging chemotherapy that patient received? Is it the inflammation that is caused by the CAR T cell earlier on? Are there clonal hematopoiesis that is already going on when the patient get CAR T cell therapy? So I think we need to understand a lot more about it before we can conclusively say that there is association of CAR T with there's causation. This is just not an association, but rather causation before this equation is changed. The T cell malignancy part is somewhat surprising to me. I mean, I'll state that on record that I think the T cell part going on label is surprising, and the reason I say that is because, as I mentioned, there have been 22 cases reported in the entire FDA system and other systems and other data streams that are there to the US FDA. Out of 35,000 patients that have received CAR T cell therapy, we know that there's a general baseline rate of people developing T cell lymphoma. There is strong data to show that T cell lymphomas occur more than a patient who have non-Hodgkin lymphoma is there's a 5-fold higher risk of patient developing a T cell lymphoma after a previous B cell lymphoma diagnosis. we know that there is a co-diagnosis of B and T cell lymphoma that can happen, and you treat the B cell lymphoma and you have emergence of T cell lymphoma. For example, that was a case in Nature Medicine publication that recently was published by UPenn group, and our group has a late-breaking abstract at ASTCT, where we talk about that particular phenomena as well. So it was somewhat surprising that T cell part went on the label without further investigation about truly if it's truly related or not. So that
Yeah.
was surprising.
Yeah. Yeah, I mean, I'll just tell you what I'm reading here, and then we'll conclude with the final thoughts from both of you. But basically, it does say the FDA applies box warnings to drugs that carry risks of severe adverse reactions that may lead to death or serious injury. And they can apply box warning to a drug at any time, including after approving it for use in the past. And there's a lot out there in terms of what constitute this. And apparently there are about 400 medications out there that have some black box warning. So I mean, good points. I think it's important to share with listeners and viewers, but I guess I'd like just final thoughts from you as, you both are in this space. I'm assuming you're really monitoring closely and you're doing your own research on it. Anything else we should tell listeners about this? Jay, I'll start with you. Anything we should have discussed that maybe I just completely overlooked?
Well, I think it's actually quite interesting. I was consenting a patient this week, and for the first time they asked me, we heard on TV that you can get secondary cancers. And I think that's really the most important thing that I'm taking away from it right now is really counseling patients on it. It's certainly always part of my auto transplant talk as far as kind of the incidence of secondary AML and MDS after doing auto transplants for lymphoma or myeloma. And now I think it's going to become just a much more integrated part of my consent for patients undergoing CAR T. I mentioned the T cell malignancy part, but I spend actually most of my time when talking about secondary malignancies, talking about the secondary MDS and AML. As far as changes that I might bring into my practice, I am thinking about whether, bone marrow biopsies to look for things like CHIP, look for things like underlying dysplasia might be something that I integrate a little bit better into my practice. I think from a research perspective, that remains something that I think would be very important if we want to get an understanding of how the bone marrow is going to change pre and post CAR T. But I think clinically, it's also something that we should start considering. But I think overall, in the patient population that I'm seeing, I don't think that these warnings change whether I'm going to offer CAR T to someone, but I'm definitely going to have an informed consent discussion that discusses these risks as well.
Jay, thank you. That's very thoughtful. And it's really important to put this into perspective. It is going to be in every informed consent, justifiably so, but it's about how you perceive the information. I'm still intrigued by the number that Saurabh said, 35,000. I don't know if everybody who's listening knows how many patients have received CAR T or all of this. So that's really very helpful. Saurabh, any final thoughts from you? Anything else you'd like to share?
No, I think, Shadi, you covered a lot of important between these two podcasts. I think we got a lot of ground covered, and Jay elegantly summarized our thoughts. I think just final thoughts would be, I think would be the overall benefit risk ratio of administering CAR T in the approved settings we are in right now still remains unequivocally in favor of and in administering CAR T cell therapy. These patients are in need. In chemorefractory second-line large B-cell lymphoma, we know there's survival benefit in randomized studies, which is the gold standard that we all believe in. So I think it's quite powerful that those survival benefit data exist in our field. For future research direction standpoint, I think I echo what Jay said, that I think we probably need to understand more about clonal hematopoiesis in these patients. We need to understand more about inflammation and role of inflammation after patients get CAR T cell therapy and how it changes clonal hematopoiesis afterwards. It's an important topic. And lastly, I think a very broad philosophical point would be that I think CAR T has been under the lens. I mean, nobody's studying CAR T I don't remember of any other therapy where the patients are being studied in 10 different directions or with 5 different specialties in the hospital. So it's under the lens. The more you look, the more you find. And that's the right approach. But again, I think we should zoom out as well and just think about, would our treatments be of benefit to that particular patient that's in front of us or not? So, and I still feel that I think CAR T overwhelmingly benefits the patients despite of these warnings.
You hit the nail on the head. It's about benefit-risk ratio, right? I mean, nothing that we do in oncology or hematology, frankly, let's face it, there is no treatment that we give is entirely safe. I mean, none. There is no treatment that you guys prescribe that you can tell a patient will carry zero risk. So it's really benefit versus risk. Well, thank you so much, Dr. Saurabh Dahiya on the West Coast and Dr. Jay Spiegel, half asleep on the East Coast. Thank you so much for coming on the HemOnc Pulse. I would love to have you again as this story evolves. Since you broke it on the HemOnc Pulse, I get the exclusive right on the HemOnc Pulse that you come back on this show.
Sounds good, Shadi.
Thank you for having us.